Our next presenter is Dr. Leif Ellisen, who is professor of medicine at Harvard Medical School and head of the breast cancer program at Mass General Hospital. Dr. Ellisen's laboratory has been studying mechanisms of resistance to antibody-drug conjugates and actually has the first manuscript describing somatic mutations as a potential resistance mechanism to ADCs. So you are well placed to provide some insight into mechanisms of resistance.
Thanks very much. I'd like to thank the program committee for the invitation and also the prior speakers for setting up this topic so nicely. Clearly this is an area about which we're all very excited in the field of breast cancer. But I think that also we realize the challenges, and probably by the end of this talk, you might have an even greater appreciation for the complexity and the challenges faced by trying to appropriately and optimally employ and design ADCs. These are my disclosures. So you've seen lists from the other speakers on ADCs that are targeting breast cancer, multiple agents in development. I just wanted to use this slide to introduce my talk. Three of the topics I'll be covering are: number one, a little bit of reiteration on the structure and design of ADCs, but specifically with respect to how that relates to potential and established resistance mechanisms. Secondly, a review of mechanisms that have been identified in vivo for de novo and acquired resistance to ADCs. And then finally, looking ahead, thinking about what are the approaches we can use to systematically understand possible resistance mechanisms to give us a head start in thinking about how we might sequence these drugs and how we might develop combinations to overcome resistance. So I'll start with sacituzumab govitecan, of which you've heard about substantially today, which I may refer to as SG. Key features of SG are targeting the EpCAM-like molecule TROP2, the fact that its linker is not only cleavable but also hydrolyzable in the low pH of the extracellular milieu, suggesting that significant payload may be released even prior to internalization and intracellular processing. And thirdly, the payload, the SN38, a topoisomerase 1 inhibitor. And we can contrast that, as we've heard, with trastuzumab deruxtecan, about which we heard such exciting data this morning. Trastuzumab deruxtecan targeting HER2, having a linker that is cleavable, a tetrapeptide structure, but typically cleavable only upon intracellular processing. But notably, not requiring necessarily fusion with an active lysosome intracellularly, but rather endosomal processing that can release the payload. And then intracellularly, once the payload is released, that payload is cell permeable, creating a type of bystander effect that results from efflux of the payload from the cell to the outside microenvironment. And then a payload which is again a topoisomerase 1 inhibitor. So what are the considerations related to ADC resistance? And it's a little bit hard to read, but I just wanted to take a minute to go through this slide to kind of give you an idea of the whole waterfront of types of things we might bring into consideration as we're thinking about ADC resistance. So obviously we have the target. We have not only its expression, its level of expression, but the heterogeneity in that expression intratumorally between different cells in the same tumor. We have the idea about how is that molecule typically trafficked within a cell and how rapidly does that occur. And then finally we have the characteristics of the target itself. We have the idea about, is the signaling mediated by the target really critical? And here we can actually divide that into two parts. If you think about HER2, of course, we think about oncogene addiction and intracellular signaling. but it's also important that the possibility that the target may signal in the extracellular milieu. A molecule like TROP2 may have important interactions extracellularly, which may impact on the therapeutic response to TROP2 targeted ADCs and therefore impact on resistance mechanisms. When we're thinking about the antibody itself, obviously target affinity is important. One thing I was quite struck by when we started doing some of the experiments in the laboratory was the internalization rate and how vastly it differs from different antibodies to the same target, targeting different epitopes, even if those epitopes were bound with the same affinity. So internalization rate, really critical. And critical not only for processing as we traditionally think about release of the payload, but also critical for perhaps other functions related to ADCs, namely those which occur extracellularly, ADCC, antibody-dependent cellular cytotoxicity, and antibody-dependent phagocytosis. Clearly, if we just want internalization and payload processing and release, we want rapid internalization. If we think that there could be a beneficial ADCC effect, perhaps we don't want immediate and rapid internalization. All important considerations. We've talked about the linker and its stability, and you really have this contrast between TDM1, which is a stable linker requiring really fusion with an active lysosome in the cell to release payload. We think about TDXD, which is this peptide that requires intracellular processing but not necessarily a competent lysosome. And then SG, which can even release payload in the extracellular milieu without necessarily internalization. And then, of course, we have the payload, its mechanism of action, its potency, its cell permeability, if we want to get a bystander effect from a release from intracellular to extracellular. And then we have, obviously, the drug-antibody ratio. And then, all the considerations that we think about with tumor therapy come into play, right? What is the intrinsic sensitivity to the payload? What are the lysosomal processing? Is the lysosome, intact in the cells? And what about the level of the standard efflux drugs that we think about that cause chemoresistance, right? Much of what we've heard has to do with ADCs which deliver chemotherapy, right? So to the same degree that, multi-drug resistance protein, P-glycoprotein, can efflux other chemotherapy, that's going to be a mechanism of resistance to ADCs. And then obviously, thinking about, in the case of HER2, we've learned with TDXD that we don't necessarily need target addiction, since we don't believe we have that with HER2 low tumors, as we do with HER2 amplified tumors. But clearly, if we do have a target to which the tumor is addicted, that could be part of the beneficial response, and overcoming addiction could be part of resistance. So just a couple examples on how this plays out related to what we've heard and what I've told you. TDM1, as we said, with a very stable linker. You see the approval there and the mechanism. We know that dependence on internalization, additive effects of a pan-HER2 inhibitor, which increased internalization, seem to be quite prominent for TDM1 because so much of the effect was related to internalization per se. The contrast with deruxtecan, as we said, because of the less stable linker. Even early studies showed that you could see in vitro resistance to TDM1 mediated by loss of lysosomal integrity, and that resistance could be overcome by TDXD because it doesn't require an active lysosome to release payload intracellularly. And we don't know for sure, but perhaps that contributes to some of the very exciting data we saw for the use of TDXD after TDM1 in advanced HER2-positive breast cancer. And then finally, SG with its relatively unique, unstable, pH-labile linker, where you get all of this microenvironmental release, both pros and cons, right? Perhaps with great tumor heterogeneity that could overcome some of the resistance because of the extensive extracellular, intracellular bystander effect, but on the other hand, may relate to other toxicities such as myelotoxicity from free payload being released. Here's some examples from the literature on in vivo resistance mechanisms to ADC. So we have the CD33 targeted ADC for AML. One of the most fascinating mechanisms of resistance is actually a single nucleotide polymorphism which essentially deletes the epitope for the ADC, and it's been shown that that really is quite an important in vivo mechanism of resistance to this drug. Similar to many ADCs as we're here, drug efflux transporters, their upregulation is important in mediating particularly acquired resistance, and then upregulation of various survival and metabolic pathways, important as it is in many chemotherapy resistance contexts. The CD30 targeted drug for Hodgkin's disease, again, drug efflux, a critical mechanism that has been recognized for in vivo resistance. And then TDM1, again, because of its dependence on internalization, HER2 downregulation has been documented as a probable mechanism of regulation, as has been altered internalization, as we said, which might be able to be pharmacologically modulated to enhance sensitivity, and then a whole host of resistance mechanisms based on the payload, again involving drug efflux, activation of survival pathways, and other factors we typically associate with chemotherapy resistance. And the list goes on, but you get the flavor and the underlying theme that so far at least, most of the in vivo documented resistance mechanisms have to do with either modulation of the target or modulation in a chemotherapy kind of resistance way of the payload. So now if we start to look at some specific data in the breast cancer context, these are data from the phase 3 ASCENT trial with sacituzumab govitecan. And on the left, you can see progression-free survival. This was comparing to treatment of physician's choice. So progression-free survival obviously greater. And then when you looked at TROP2 levels, there seemed to be a numerical trend of progression-free survival related to TROP2 levels. This did appear to be a predictive and not purely prognostic effect, because you saw no such trend with TPC, but you did see it with TROP2. Obviously, much more data needed to understand this. In our own group, we started collecting some cases of patients treated SG, where we had not only the primary tumor, but we also had multiple autopsy specimens from a rapid autopsy program launched by Dan Urich in our group. So we had the ability to think about what was going on in the setting of both de novo and acquired resistance. First, we looked at the correlation between response and TROP2 levels in the primary tumor, and this is a few of the selected patients. One of the patients had a very dramatic response, more than 8 months on the drug. Another patient had an intermediate response, 5 to 6 months, and another patient clearly had de novo resistance. When we looked at TROP2 levels, indeed the patient with de novo resistance had 0 TROP2 at either the mRNA level that's shown in the blue or the IHC that's shown on the top right. Interestingly, the patient who had the deep and prolonged response not only had high levels of TROP2 protein and RNA, but also amplification, genomic amplification of the TROP2 locus on chromosome 1p. And this latter patient turned out to be a fruitful one to study, because it was clear that the patient had had near complete regression of several metastatic lesions, but then regrowth and progression, and we were able to capture those lesions at the time of rapid autopsy. So we thought that it would be a good case study for acquired resistance. And to do this analysis, we teamed up with Gad Getz, who has developed a number of computational algorithms where you can do exome sequencing of every metastatic lesion, and then through inference and mutational calling, you can reconstruct the phylogenetic evolution of resistance in the patient, and you can see how the tumor has gone down different paths in terms of its sequential mutational evolution. And what I want to draw your attention to are the two, let's call them the red and the pink branches of evolution, which were prominent in this patient. On the right, you see this pink branch, which was hallmarked by the acquisition, again, a mutation not present in the primary tumor, in topoisomerase 1. And this was very exciting for us to see, because the mutation was E418K. And E418K, if you read the literature about topoisomerase 1, if you hit a cell line in vitro with very high levels of topoisomerase 1, That's what you get in the resistant cells, is this very mutation. It alters the way the topoisomerase binds to DNA, disabling its binding to DNA, and therefore inducing resistance to the inhibitor. And then subsequently, a mutation evolved, which is a nonsense mutation, which we believe evolved on the other allele. So this part of evolution, this regrown tumor, harbored this canonical TOP1 mutation, which we understand very well. Equally interesting was another branch and another set of lesions which developed a mutation in TROP2. This was not a known mutation. It was a missense mutation of a threonine to an arginine, but obviously a non-conservative change, and was present in many lesions. When we looked at the physical location of these mutations, it was interesting to see that all of the lesions harboring TOP1 mutation were below the diaphragm, and all the lesions harboring the TROP2 mutation were above the diaphragm. But what I haven't told you is, do we have any evidence that this TROP2 mutation is really meaningful? So that's what we then went into the lab to do, and we were able to show that this mutation, this is a little schematic of TROP2, as I said, highly related to EpCAM. It's in the juxtamembrane conserved domain, and we were able to show that this mutation does not affect the level of TROP2, but here you can see in panel C by FACS analysis that it affects the cell surface localization of TROP2, and indeed you could show that you can reconstitute the wild-type TROP2 and make cells sensitive to SG. If you reconstitute the mutant, they are not sensitive to SG in the same way. And you know, the picture worth 1,000 words was this confocal immunofluorescence image, which was developed by Nayana Timia in the lab, and she was able to show that here these are individual tumor cells, wild-type TROP2, beautifully localized to the cell membrane, but this missense mutation entirely localized intracellularly. So quite a plausible mechanism of resistance. So ultimately, what does this tell us? And if we take a step back, is it important? Well, I mean, from one perspective, it's clear that to know whether the mutation involves the payload versus the target is important. If you have a resistance mutation involving the target, topoisomerase 1, perhaps sequential use of another ADC that targets topoisomerase 1 could be less efficacious. Conversely, if TROP2 is no longer on the cell surface, a TROP2 targeting ADC is maybe not the best choice. So understanding and cataloging and ultimately, recognizing these mutations in individual patients is going to be a challenge. The even bigger challenge, as you recognize from this individual patient, is that both of these mutations were coexisting in the same patient. And this gets to the idea I'll come to in a moment about perhaps we have to really hit the tumor harder to begin with to prevent such resistance from occurring in the first place. And so that gets to our really systematic look at resistance. And one of the ways we're doing that, as have other groups, is whole genome CRISPR screens. For example, Michael Basik's lab at Stanford has done beautiful work doing systematic CRISPR screens to show how different linkers require different steps in endolysosomal and lysosomal processing in order to release payload, and his work has articulated that very well. We did a study using SG in triple-negative breast cancer cells in a genome-wide CRISPR screen in collaboration with the Broad Institute. And this is what they call the volcano plot of the entire genome-wide CRISPR screen. So it's a CRISPR screen, so the loss of the genes listed is what we're talking about. So on the right, the loss of these genes causes resistance, and on the left, the loss of these genes causes sensitization. We were gratified that when you put these into pathways in this network analysis, a lot of it comes up to be what we would expect. Numerically, the largest number of genes are those associated with topoisomerase 1 resistance sensitivity, namely homologous recombination and replication-associated repair. But you also see here these pathways that we've been talking about relevant to ADC-specific resistance, endosomal trafficking, and others. What immediately struck our attention first, though, was this one. In the entire genome, the number one resistance-inducing hit was PARG. This is a glycohydrolase whose specific effect is to oppose the effect of PARP1 within the cell. So PARP obviously is ribosylation, creates these chains, and PARG hydrolyzes them. And so PARG, the top resistance hit in the entire genome, and PARP1 among the top sensitizing hits in the entire genome, suggesting very strongly that the PARP pathway is critical to sensitivity to SG. Not a huge surprise. It's well recognized that the way the topoisomerase worked, as I said, is this SN38 here intercalates between topoisomerase and the DNA, stabilizes this complex so it can't be cleaved and ultimately leads to a double-strand break and death. And that the resolution and elimination of this stabilized complex when you give a topoisomerase 1 inhibitor is highly PARP dependent. There's multiple mechanisms of this, but suffice it to say that is well described. So in theory, a great combination with any topo-1 inhibitor. The problem was, however, that in patients, giving intravenous topo-1 inhibitor and a PARP inhibitor was just intolerable. Really, almost innumerable clinical trials initiated and were unable to be completed because of toxicity. And this is the on-target toxicity of the synergistic effect of a topo-1 inhibitor and a PARP-1 inhibitor in tumor cells as well as normal cells. But we hypothesized, and this I really give a lot of credit to Aditya Bharti in our group, we hypothesized that the ADC mechanism might allow us to overcome this, this lack of a therapeutic window. And we thought about it in two ways. One, the idea that, of course, with an ADC, you're getting more tumor-selective delivery of the payload, and that might help us overcome some of that problem. But also, the fact that you have massively more accumulation of the drug within the tumor would create not only perhaps more of a therapeutic window, but also a temporal window. And the argument goes like this. If normal cells are accumulating perhaps small amounts of topo-1, that's going to be cleared out and resolved in a short period. Tumor cells, which might have as much as 100 times more of the payload accumulating, will take longer to rid themselves of that drug. And so if you give the ADC, you get the drug in the cells, and then you wait a little bit for the normal cells to clear it out, and then give the PARP inhibitor, perhaps that could be a successful approach. And so this was the trial that Aditya launched, and we did have some lab proof of principle for this idea. And so here is the trial that Aditya launched, where we give 2 doses on days 1 and 8 of SG, and then come in on day 15 with talazoparib, the PARP inhibitor that we used in this study. This is phase 1b/2. I'll give you some of the safety data from the phase 1b that Aditya presented at ACR earlier this year. The phase 2 study for efficacy is currently enrolling. But of course, first we were in the lab to say, is there any validity to this hypothesis that you can separate these 2 drugs in time and get anything to happen? And the answer, of course, is yes. 468 is a triple-negative breast cancer line, and we could show that if you give SG, you completely wash it away, and then give the PARP inhibitor, you still have quite dramatic and synergistic efficacy and cell killing. Naturally, the longer you wait, the longer the interval between the two, the less it becomes, but nevertheless, quite potent synergy for the 2 separated in time. Doesn't occur with normal cells because you have little drug in normal cells and they're not intrinsically sensitive to either PARP or topo-1. Again, the proof in the pudding picture. These are confocal images of the stabilized cleavage complex of topoisomerase 1. So when you give SG, the topo-1 creates these stabilized complexes, which will ultimately fall apart in double-strand breaks. Within 30 minutes, these are rapidly resolved within the cell. But if instead you give the PARP inhibitor, they persist. And that's where we've shown, I won't go through all the data, but we've shown that you get very rapid accumulation of lethal DNA damage in this setting. But the key question was, would it overcome the toxicity? And so this is some of the data that was previously presented. And here we're comparing a small cohort of patients where we started with sequential therapy. We started with concurrent therapy, which proved not to be particularly well tolerated. And then we went to the sequential dosing. So you can see 71.4% dose-limiting toxicities in the concurrent scheduling of SG and talazoparib, but 0% with the staggered or sequential dosing. And here you can see each of the adverse events here, which were all substantially lower. Again, this was a dose escalation, so we're not going to say much about efficacy other than to say that there were substantial responses, and that numerically the progression-free survival was higher with the sequential dosing. And this was, of course, as you might expect, because so many of the patients had to come off the concurrent dosing due to dose-limiting toxicity. So this is very interesting. The hypotheses seem to be proved about tolerability, and we anxiously await the completion of the trial and the efficacy data. But I think, if you step back and think more broadly about it, we've talked about a lot of the benefits of ADCs in delivering particular drugs, but I think it's a very exciting possibility to think about ADCs is allowing us to think about therapies that never really were possible, right? Either because of overlapping toxicities, because of temporal concerns, or other concerns. And so I think we have a lot of unique opportunities as we think about how to overcome these vexing resistance problems. So finally, I'm going to close with some of the latest data in the lab. And this is really thinking about, looking very deeply at the specific mechanisms related to not only the payload, as we've been talking about quite a bit, but also related to the ADC and its processing. And so once we finished this initial series of CRISPR screens, the next thing that we did was do a series of parallel screens where we did them with SG and side by side with SN38. So we could really isolate the hits, the genes, the pathways that were specific for the ADC itself, and we didn't see them with just a topo-1 inhibitor. This is just a teaser, but it's getting very exciting. So for example, we have multiple TNBC lines, and we treat them with SG, SN38, and do CRISPR screen. There's a lot of overlap and sensitivity between the lines, as we would guess, and a lot of overlap between the hits that we get with SN38 and SG, as you would expect. This is looking specifically at the resistance hits, right? Loss of these hits cause resistance. There were a relatively few number, but there was one standout pathway, and that was proteoglycan biosynthesis. And this really makes sense from the point of view of what we understand about the ADCs, because we know that these pathways are important for receptor endocytosis, protein internalization, and endolysosomal fusion, which is all critical, as we've been talking about, to ADC processing. So rather gratifying. These hits really are coming up. They're really ADC specific. Pursuing them specifically is, I think, going to hopefully give us specific clues about pinch points, key targets that might be the failure points for inducing resistance. And then conversely, we did the same experiment with inducing sensitization, right? Here we're thinking about hits that we could perhaps inhibit to combine. And this was quite interesting and, in fact, unexpected. Again, it's the same experiment, SG versus SN38, multiple TNBC lines, a lot of overlap, but a key set of genes whose loss induced substantial sensitivity, but only to SG and not to SN38, the topo-1 inhibitor itself. And interestingly, clearly the number one pathway was ubiquitin-mediated proteolysis. A little bit of the surprise, given the known role of this pathway in topo-1 function. What it's turning out to be the answer is the specificity in the ubiquitin-mediated proteasome system, and this is all work done by Bogong Wu in the lab, the specificity for particular targets that are related to ADC targeting and processing that are deregulated to induce sensitivity. So in this case, it's really going to be about the specificity. Obviously, we have to look at cell type, different tumors, all these other things, but really an exciting idea that perhaps even repurposing drugs, which we know of, which target the ubiquitin proteasome pathway, we could induce sensitization in the right setting. And so this is a very active investigation in the lab, together with obviously a large expansion of the efforts I described for rapid autopsy and systematic analysis of de novo and acquired resistance. So finally, to summarize the points that I've told you, resistance mechanisms to ADCs are likely to be diverse given their multifaceted mechanisms. To date, the well-established in vivo mechanisms involve primarily the target and the cytotoxic payload. Considerations of distinct antibody linker and payload features will govern cross-resistance and govern how we do sequencing of ADCs. The sequential use is likely to be effective, but in an informed clinical setting. And finally, that the systematic analysis of distinct mechanisms coupled with analysis of patient material will accelerate development and indeed be essential for new ADCs and combinations to prevent and overcome resistance. Thanks very much for your attention.
Well, I think you made your point that this was going to be complicated. Um, questions
Lots of
for
work to
Dr.
do.
Ellison?
It's a great talk, thanks. Your idea of combining the SG the immediate delivery plus the talazoparib, which is PARP1 inhibitor, but there are several isoforms of PARP1, like 11 to 14 isoforms I heard from a PARP1 expert. What do you think of that situation when you combine that, resistance emanating from the isoform, rescuing the phenotype?
Yeah, there's kind of an echo here, but it had to do with PARP and different isoforms and other things. The screen, the only PARP that came up was PARP1, which that came up for that gene knockout, which I think is a promising point because it alludes to the fact that we can use more selective PARP inhibitors, right? There's also the question of whether PARP trapping is going to be necessary or desired in the setting of the PARP combination. Talazoparib, as you know, has significant trapping, but it's possible, given that the knockout of PARP was sufficient to induce a lot of sensitivity, that we could use a selective PARP1 inhibitor that didn't necessarily have a lot of trapping effect, that might be even better tolerated, and so I think that's an exciting possibility.
Okay. My second question is, most of the ADC conjugates target the tumor cells, but the tumor microenvironment is doing a lot of rescue. That might be a point to consider, and of course immunotherapy is there, that point could be combined.
Yes. It's just challenging to hear there's an echo, but I think it's going to be really important, particularly as we look at immune checkpoint combinations and others that are really targeting the microenvironment, that we think about how the engagement of a specific target is affecting the tumor microenvironment, right? Because the engagement of the target in the microenvironment, depending on what the target is, could substantially influence what's happening there and could substantially influence the interaction with things like immune checkpoint inhibitors.
What I meant is, like you target the tumor cells with specific delivery, we may also have to target like TAMs or CAFs in addition to targeting the tumor cells. Like TROP2-based delivery, similarly you have to target like FGF2 receptor-based delivery to CAFs simultaneously so that you get the holistic effect.
Yeah, that's an exciting possibility.
Okay, last question.
Thank you very much. Dr. Ellison, thank you, but this is more of a question for Dr. Modi and Dr. Sapra. Given that breast cancer, and I'm Mike Dugan from Biocept, given that brain metastasis is a leading cause of breast cancer death, and the drug concentrations of trastuzumab in the CSF are significantly less than in the plasma when delivered systemically, could you give us some thoughts about the potential use of these antibody drug conjugates in an intrathecal administration, similar to what Dr. Priya Kumtekar described for intrathecal trastuzumab recently? And specifically to avoid maybe to heighten the delivery of the drug while avoiding the complications of lung toxicity.
I guess I'm not aware of intrathecal. However, there is growing evidence that when blood-brain barrier is compromised in these settings, and trastuzumab and biologics have penetration, which is helping with the TDXD efficacy.
We're still at the point of doing window of opportunity studies with TDXD. I think we want to learn more about what happens when we give this drug systemically in these compartments, I think, before we're brave enough to try intrathecal ADC therapy.
Thank you very much.
Thank you to all the speakers. This was a very comprehensive and informative session. Thanks very much.